Hello all, welcome to my YouTube channel, that is Biochemistry Basics by Dr. Amit. Today's topic is case-based discussion on diabetes mellitus. Such type of case studies are asked frequently in various theoretical exams as well as in various competitive exams. So me and my team has tried to incorporate different type of case studies on diabetes mellitus, which will help you to understand this topic more better way. Let's see what is the first case. The case study one is 58-year-old man having 82 kg weight with frequent urination is seen by his primary care physician. The following laboratory and the following results were obtained. First result was random blood glucose value was gram per deciliter, and the urinary results are pH was 6.0, specific gravity is 1.025, glucose was 2 plus, there was a presence of glucose in the urine, while ketone body, blood bilirubin, urobilinogen, nitrites, and leukocytes were absent. So that is the urinary results. Now let's see what are the various questions are. So the first question was, what is the probable diagnosis? As we in the information from the description that patient's age was 58 year and the patient was relatively obese and patient was having complaint of frequent urination. Thus, patient's random blood glucose was 225 milligram per deciliter. That is the more than the normal range. Normal range for the random blood glucose is 80 to 140 milligram per deciliter. So that is the higher range. So it is a hyperglycemia. Plus, there was a presence of glucose in the urine as well. That is glucosuria. So all this clues, all this information is pointing toward only one diagnosis, that is diabetes mellitus. And in the diabetes mellitus, it is a type 2 diabetes mellitus because the age of the patient was 58-year-old and the patient was obese. That is the type 2 diabetes mellitus. Now let's see what is the second question is. What other tests should be performed to confirm this, which is the preferred test? Now we can do two tests to confirm the diagnosis. One is the oral glucose tolerance test, that is OGTT. In that, we have to give the 75 gram of anhydrous glucose, and we have to collect the sample. First, we have to collect the sample in the fasting stage. Then we have to give the 75 gram of glucose, and then we have to collect the sample at the 1 hour interval and at the 2 hour interval. Another test we can do is HbA1c test, which is the more advanced test as compared to the OGTT for the diagnosis. Second question is, which is the preferred test? So now to among OGTT and HbA1c, nowadays HbA1c is the preferred test because HbA1c gives average blood glucose value for more than 3 months. It is the more advanced test, and the sample for the HbA1c is stable as compared to the sample for the blood glucose. So that is the answer of second question. And in the OGTT, we need to collect the blood for the 3 times, as compared to the in the HbA1c we have to collect the sample for the single time. So that gives major relief to the patient as well. So that is the another point you can add. Now let's see question number 3. After diagnosis, what tests should be performed to monitor his condition? Now, once diagnosis is done, we can do HbA1c, fine, which is the advanced test available. Again, it gives average blood glucose value for the 3 months, that is around 120 days, which is equivalent to the lifespan of RBC. Then it is more stable as compared to the blood glucose estimation. Another major advantage of HbA1c is we don't require fasting for the HbA1c. We can do HbA1c in the random state. Fine. Other tests apart from HbA1c, you can do FBS and ppBS for the monitoring purpose. That is fasting blood glucose, and ppBS is the postprandial blood glucose. For the fasting blood glucose, there should be around 10 to 12 hour of fasting, and in the postprandial blood glucose, uh, glucose sample is collected after taking glucose sample is collected after 2 hours of taking food. So that is the question number 3. Now let's see what is the other cases. Case number 2. A young man with type 1 diabetes mellitus attended the OPD department for his regular follow-up and reported that he had been symptom-free since his last clinical attendance. He had been taught how to measure his own blood glucose concentration with the help of glucometer, of course, but didn't do this because he didn't like pricking his finger to obtain blood for testing. So that is the case description. Now, investigations are blood glucose, that is 2 hours after breakfast, is 198 milligram per deciliter. Then urinary glucose is 2 plus, and HbA1c is 7%. Fine. So these are the investigations. So now, what are the various questions? The first question is, what is HbA1c and how it is formed? So HbA1c is basically a glycated hemoglobin, and it is formed by glycation process. Glycation is basically addition of sugar to the protein non-enzymatically. That is glycation, right? Which is different from glycosylation, which is uh, addition of sugar to the protein by enzymatically. Glycosylation is basically a post-translational modification. So that is the answer. And HbA1c is formed by addition of glucose to the beta terminal of hemoglobin. There is a beta chain, and beta chain in beta chain there is an amino terminal. So glucose is attached to the amino terminal of beta chain of hemoglobin in the valine amino acid. So this is how this HbA1c is formed. So that is the answer of this question number one. Second question is, what are the advantages of HbA1c over blood glucose estimation? So it is already discussed in the previous case that HbA1c gives average blood glucose value for the around 10 to 12 weeks. It is more stable as compared to the blood glucose estimation. There is no need, no requirement of fasting for the HbA1c. Then in the HbA1c, there is a low intra-individual variability. So these are the various advantages of HbA1c over blood glucose estimation. Third question is why there is a presence of glucose in the urine. So in the description, we have seen that there was a presence of glucose in the urine, that is plus 2. So that is glucosuria. So glucosuria will be seen whenever whenever there will be the plasma level of glucose of the patient is more than 180 milligram per deciliter. That is called as a renal threshold for the glucose. For the glucose, renal threshold of glucose is around 180 milligram per deciliter. Whenever the plasma level will be above 180 milligram per deciliter, at that time there will be the appearance of glucose in the urine. So that is the reason why glucose is seen in the urine. And this renal threshold is reduced physiologically in pregnancy. So these are the answer of various questions. And the patient's HbA1c was around 7%. So that is called as an adequate control. Fine. So that is case 2. Now let's see case number 3.
If you've ever opened 20 tabs on Google Scholar trying to figure out what the research says, watch this. Normally, researching a topic means dozens of reading through papers. With the Scholar agent by Consensus, that all happens in one click. Consensus automatically breaks down your query.
So case number 3. 13-year-old girl collapsed on playground at school. When her mother was contacted, she mentioned that her daughter had been losing weight and making frequent trips to the bathroom in the night. The emergency squad noticed a fruity breath. On entrance to the emergency department, her vital signs were as follow. So this is the case description. And these are the vital signs. Blood pressure, systolic is 98 and diastolic is the 50. Respiration was rapid and temperature was 99 Fahrenheit. And the laboratory investigations are in the urine, pH is 5.5, protein is negative, glucose is 4 plus, ketones are moderately seen, blood is negative, so that is the random urine sample. And in the serum chemistries, glucose level is 500 milligram per deciliter, ketones are also positive in the blood. Sorry, ketones are also positive in the blood. Blood urea nitrogen is 6 milligram per deciliter and creatinine is the zero point 0.4 milligram per deciliter. From the investigation, we can say that pH is quite acidic. There is a presence of glucose as well as ketone in the urine. Glucose is quite high, fine, 500 is very much high. Then there is also presence of ketone body in the blood. Blood urea nitrogen and creatinine, we can say it is normal. So let's see what are the various questions. Uh, Sorry again. So the probable diagnosis from the lab investigation, we can say that the blood glucose is very high. Random blood glucose is very high, 398 milligram per deciliter. So that is hyperglycemia. In urine, there is a presence of glucose. So that is glucosuria. In urine, there is also presence of acetone. That is ketone body. Thus, bicarbonate is very low. Fine. That is the first thing. Sodium is also low. The normal value of sodium is 135 to 145 milliequals per liter. So that is hyponatremia. Potassium level is high. Normal value of potassium is 3.5 to 5 milliequals per liter. So this is hyperkalemia. Patient is also hypotensive, and there was a history of frequent urination also. So this all things point towards acute complication of diabetes, that is diabetic ketoacidosis. There is a acidosis as there is this excretion of ketone bodies, and these ketone bodies are basically acid, right? So to compensate that pH imbalance, there is a more utilization of bicarbonate. So bicarbonate will also be utilized. That's why bicarbonate is low. And there, as there is an insulin deficiency, so potassium will not be utilized. So there will be the hyperkalemia. And so that is the diagnosis of DKA, biochemical basis of production of ketone bodies in case of diabetes mellitus. Now this one is interesting. So as we all know that in diabetes mellitus there is an insulin deficiency. Insulin deficiency, glycolysis is prohibited. So there will be the enzymes of glycolysis will not work properly, and gluconeogenesis will be more operating. So there will be the more hyperglycemia. Now, for the gluconeogenesis, we require oxaloacetate. Fine. So oxaloacetate will be utilized in the gluconeogenesis. And in the insulin deficiency, there will be the lipolysis will also be there. So there will be the more production of acetyl CoA. Now, this acetyl CoA in insulin deficiency, generally this acetyl CoA oxidized via tricarboxylic acid cycle, that is called as a TCA cycle. Now, in diabetes mellitus, as there is an insulin deficiency, so, and as there is insulin deficiency as well as oxaloacetate, which required for the TCA cycle, is utilized more in gluconeogenesis. So, there is a deficiency of oxaloacetate as well. So, this acetyl CoA will channel towards the ketone body synthesis. Acetyl CoA is the substrate for the ketone body synthesis. So, it will lead to the more synthesis of ketone bodies. Generally, there are three ketone bodies. One is the acetone, second one is the acetoacetate, and the third one is the beta hydroxybutyrate. So that is the explanation why there is a synthesis of ketone bodies in the case of diabetes mellitus. Third question is, what are the cardinal symptoms of diabetes mellitus? There are the three cardinal symptoms of diabetes mellitus, that is polyuria, that is excessive urination, polydipsia, that is excessive thirst, and polyphagia, that is excessive hunger. So these are the three cardinal symptoms of diabetes mellitus. Fine. Fourth question is line of treatment for this case. So the first, so this is the case of diabetic ketoacidosis. The first you have to give the intravenous insulin. That is the first thing that you have to do. Second thing, you have to also administer bicarbonate as there is a low bicarbonate level. Then you have to correct the water and electrolyte imbalance, and you have to give the antibiotics also if there is any kind of infection is present. So this is the line of treatment for this case. Insulin along with the glucose. That thing should be in your mind. Don't give insulin alone. You have to give insulin along with the glucose. Fine. So that is the line of treatment for this case.
Come with us behind the scenes of our virtual Masters Open Day. This is what you as the audience see, and this is what we see.
So here are the cameras which are capturing the event as it happens.
This is the auto cue. This is where we get all of our intros, and then
Case study number 5. This is the last case, and this one is also interesting one. 28-year-old woman delivered a 9.5 lb, that is 4.3 kg infant. Infant was above the 95th percentile for weight and height. The mother's history was incomplete. She claimed to have had no medical care through her pregnancy. Shortly after birth, infant became lethargic and flaccid. A whole blood glucose and ionized calcium were performed in the nursery with the following result. The whole blood glucose was 25 milligram per deciliter and ionized calcium is 4.9 milligram per deciliter. And the plasma glucose was drawn and analyzed in the main laboratory to confirm the whole blood findings. So in plasma glucose was 33 milligram per deciliter. An intravenous glucose solution was started and plasma glucose was measured hourly. So from the investigation, we can say that blood glucose level is very low, that is hypoglycemia. It is generally less than, so it is a more severe because it is less than 45 milligram per deciliter. So that is a severe hypoglycemia. Now let's see what are the various questions. The first question is, give the possible explanation for the infant's large birth weight and size. In the description part, we have already seen that the birth weight of the baby was around 4.3 kg. So this is the probable case of gestational diabetes mellitus, which leads to large baby. Fine. In gestational diabetes mellitus, what is happening? In mother, there is a hyperglycemia. Now, in response to that hyperglycemia, fetal start secreting insulin more. That insulin leads to increase in the DNA synthesis as well as increase in the cell size. Right? So that leads to infant's large birth weight and size. So that is the possible explanation. Fine. So that is the answer of question number 1. Question number 2. If the mother was gestational diabetic, why was her baby hypoglycemic? So there are the two reasons for that. As there was a more insulin secretion from the baby, so that leads to hypoglycemia. Fine. And the second reason for that, as soon as umbilical cord is cutted, so that leads to hypoglycemia. Fine. So that is the two possible reasons why baby was hypoglycemic. Fine. Third question, why there is a discrepancy between the whole blood glucose concentration and plasma glucose concentration. So this discrepancy is due to because plasma glucose contains more amount of water as compared to the whole blood. So that is the reason for the discrepancy between whole blood glucose and plasma glucose. In the investigation part, we have seen that whole blood glucose is quite low as compared to the plasma glucose because plasma glucose contains more amount of water. And so that is a possible reason.
This is the computer mixer. You can see for all the computer mixer, we have a small control panel over here, and this is the electric automatic lubrication station. This is very good for the lubrication of the computer mixer, and sometimes for the manual lubrication has a lot of the problem, and this one has no problem. It is very easy for the maintenance.
And the last, if the mother had been monitored during pregnancy, as she gave the history that she has not done any kind of antenatal visit. So if the mother had been monitored during pregnancy, what laboratory tests should have been performed and what criteria should have indicated that she had gestational diabetes? So first, we should understand that what is gestational diabetes. So gestational diabetes is basically a type of diabetes which is developed at the time of gestational period. If mother is already diabetes and she become pregnant, then it is not called as a gestational diabetes. So that is the first what is gestational diabetes. Now For the diagnosis of gestational diabetes, we can do oral glucose tolerance test. In that, you have to give 75 gram of glucose to the patient, and you have to draw three sample. That is, first there is a fasting sample, and after taking the fasting sample, you have to give 75 gram of glucose to the patient, and you have to draw another two sample. That is at the 1 hour interval, and another is at the second hour interval, and then you have to do the blood glucose estimation in those samples. And if the value of fasting sample is more than or greater than or equal to 92 milligram per deciliter, 1 hour value is greater than or equal to 180 milligram per deciliter, and 2 hour value is more greater than or equal to 153 milligram per deciliter, then you can confirm that patient is having gestational diabetes. This criteria is laid down by ADA, that is called as a American Diabetic Association. Hope hope you have liked my video. Please like, share, and subscribe Biochemistry Basics by Dr. Amit. Thank you.